Welcome back to part 2 of best practices to promote vaginal delivery. The National Partnership for Maternal Safety Consensus Bundle on Safe Reduction of Primary Cesarean Births Supporting Intended Vaginal Births also used the Readiness, Recognition, Response, and Reporting QI model. Many of the elements are very similar, and again, many of the elements are already in place. For readiness, we need to develop a unit culture which supports vaginal birth by all the team members. We need to optimize patient and family engagement. We need to adopt healthcare provider education and training. In the recognition domain, we should be providing pain management techniques that promote labor progress and prevent dysfunctional labor. Not everyone will need an epidural or want an epidural, so we have to provide them with other alternatives. We also need to use standardized methods in assessment and communication of fetal status, including methods that allow for patient movement. That would be advocating for your patient to have intermittent fetal monitoring when appropriate. We do well in the response domain. We already have in-house OB provider coverage. We use standardized scheduling and execution for inductions of labor. We adopted standards, response protocols to category 2 and 3 fetal heart rate patterns and uterine activity. And again, reporting and systems learning. We are providing data measurements that allow for comparison and evaluation of performances by providers. And we're also tracking balancing measures to ensure maternal and neonatal safety. Now I want to discuss physiologic birth. The first stage of labor contains 2 phases. Early labor, or the latent phase, that's when the cervix ripens, effaces, dilates, and the contractions are usually irregular but become more regular and increase in strength and duration. Once the patient goes into active labor, effacement is usually 100%. Dilation is greater than or equal to 6 centimeters. The contractions have increased in duration and strength and are usually much more regular. Once they are fully dilated and get to the expulsion or pushing phase, the fetal head is usually engaged and we have descent. The patient will often complain of rectal pressure or an urge to push or both. If maternal and fetal status allows, try to allow the patient to labor down, letting the uterus do most of the work. The average lengths of labor for first-time moms for early labor are 6 to 12 hours, active labor up to 8 hours, and sometimes longer labor about 17 hours. Every individual is different. There's no rule book for the length of labor. When a patient is admitted to the hospital, oftentimes the nulliparas or first-time moms are admitted prior to active labor, which we just learned is less than 6 centimeters dilated. Perhaps they're being admitted because they can't cope with the contractions, they're tired, or for an induction of labor for various reasons, whether they be medical, obstetrical, or elective. Our current labor and delivery culture, the patient is placed on a bed, on the electronic fetal monitor, and only leaves the bed for the bathroom. If prudent, advocate for intermittent monitoring, freedom of movement, ambulation, labor clear liquids diet, and upright positioning. Encourage their partners or family to provide continuous labor support, offering encouragement and praise. If the patient receives a regional analgesia, encourage upright positioning, frequent maternal position changes, and when lying in bed, use assistive devices such as the peanut ball or pillows. This is the latent phase in the first stage. It's also known as early labor. It's usually the longest phase. The cervix begins to make changes from long, thick, closed to a shorter, softer, and starting to dilate. As you can see in the picture, the one on the left is before labor, and then the one on the right is as the cervix starts to make changes. Contractions are irregular, lasting 30 to 45 seconds, and are mild. Remember, a nullipara has no frame of reference. If prudent, the NTSV should be home in familiar surroundings with continuous labor support and freedom of movement. Once admitted, freedom of movement, frequent position changes, ambulation, rocking, upright positioning, and light eating should be encouraged if the situation allows. An ACOG guideline at this stage of the labor is a prolonged latent phase, that is, greater than 20 hours, should not be an indication for cesarean. Slow but progressive labor should not be an indication for cesarean. And before 6 centimeters dilation is achieved, the active phase progress should not be applied. Next, we'll go over the active phase in the first stage, which is also known as active labor. Labor begins to accelerate. Many women have an epidural at this point, usually lasts about 4 to 8 hours, but can last longer. Contractions are more regular, closer together, they last longer, about 45 to 60 seconds, and they are stronger. During transition from 7 to 10 centimeters without an epidural, this is often the toughest and most painful part, and women may experience nausea, leg cramps, pressure in the lower back, upper thighs, and/or the urge to push before they're fully dilated. Once the cervix is fully dilated and fetal descent has occurred, the urge to push is much stronger. Continue to provide continuous labor support, frequent maternal position changes to enhance maternal comfort, upright positioning, and/or advocate for more time when the situation allows. Utilize assistive strategies such as the peanut ball or pillows to facilitate progress. The ACOG guideline suggests regular nursing care, continuous one-on-one emotional support has shown to shorten labor and improve spontaneous vaginal delivery rates. Frequent maternal position changes should provide comfort to the patient. You don't want to change the patient's position and then she's uncomfortable. You want to try to make her as comfortable as possible. The next 2 slides are an overview of the cardinal movements, which is how the fetus negotiates the pelvis. The picture A is before engagement, then we have engagement, flexion of the fetal head, and descent. The next picture depicts descent and internal rotation, and then the last picture on this slide is complete rotation and early extension. Then we have external extension, restitution, where they go back to their original position, then the anterior shoulder is delivered, and then the posterior shoulder is delivered. This is the birthing peanut ball, and its use started in the 1990s with midwives. The mechanism of action is thought to open up the pelvis, make more room for the fetus to negotiate through the birth canal. There's a link that will take you to a YouTube video which demonstrates a few of the positions that you can use with the peanut ball. Now we will discuss the second stage of labor, or the expulsion of the fetus. There are 2 phases, the passive descent of the fetus and the active pushing by the mother. Supine positioning has known adverse effects. It lowers the mother's blood pressure, and it also lowers the baby's heart rate. Upright or side lying is preferable. Defer to what seems to be working for the patient. Consider using a squatting bar. Many variables determine the time spent in this stage, also known as the 5 Ps. The power, which is the maternal efforts or the strength of the uterine contraction and activity. The passenger, which is the fetus, its position and size. The passageway, which is the pelvis shape and diameter. The placenta, which needs to be healthy and its ability to oxygenate the fetus. And also the psyche, the maternal mental frame of mind, is very important. Allow the woman to use spontaneous, which is also called open glottis, or Valsalva, which is prolonged closed glottis pushing, whatever she prefers, whatever works for her. Encourage the woman to relax her face while pushing. If her face is tense, it seems to be counterproductive to her pushing efforts. ACOG recommends, if maternal and fetal conditions permit, try to allow at least 3 hours pushing in the NTSV. Longer time may be appropriate, but should be individualized as long as the fetus and the mother are doing well. Also, operative vaginal delivery, such as forceps or vacuum, may be considered a safe and acceptable alternative with trained personnel available. And last, manual rotation of OP is a reasonable intervention. What can we do as nurses? We can provide reassurance to the woman that her body was created for this experience. We can ensure that she receives continuous one-on-one labor support, encourage her family to assume the role of doula. We can promote freedom of movement and/or ambulation in early labor with intermittent electronic fetal monitoring if conditions allow. Also, encourage frequent maternal position changes and/or movement if feasible. Encourage upright positioning if comfortable. Advocate for the patient to buy some time if the maternal fetal status allows, and utilize assistive devices such as the peanut ball, pillows or squatting bar, and frequent position changes, especially after regional analgesia. To sum it up, these are the key strategies. Improve the culture to support vaginal birth, practice good communication among the team, provide reassurance and encouragement, ensure one-to-one continuous labor support, promote freedom of movement, encourage frequent maternal position changes, utilize assistive devices, that is, the peanut ball, squatting bar, and advocate for more time when reasonable. These are my references. A special thank you to my content experts, Patricia Bartels, Madeline Cozy Gottlieb, and Lisa Lopez. I also want to thank my technical support people, Anthony Greco and Angie Hoyos. Thank you all so much.